It's my very great pleasure to introduce our speaker, Dr. Piotr Czaykowski. Dr. Czaykowski is a medical oncologist here at CancerCare Manitoba, and he's going to be presenting on putting the me in cancer therapy, personalized medicine, and treating cancer. So I'm going to turn it over to him. Dr. Czaykowski, you want to put on your camera and load your slides. I think we'll be ready to go.
Yeah, good morning and thank you. And my wife pointed out to me that me does not appear in the word therapy, so she quibbled with my title, so forgive me for that. But it does appear in the word medicine, so it does work. My equity commitment, and I have no conflicts of interest to disclose with respect to this topic. I would like to just point out that I am your fourth string presenter here. The three quarterbacks that they had asked to speak were not available, so I'm more like the place kicker. This is not my area of expertise, so bear with me, and I will walk you through things. It was good for me to learn all this as well. So the topic was personalized medicine, and we're going to cover a few things. Hasn't cancer always been personalized? Have we moved really from personalized to precision medicine? A little bit on biology, about some of the molecular techniques that are used, and what does it all help with? So hasn't cancer always been personalized? So yes, to a degree. We've always considered things like age, and it's not ageism. It really does have a role as the body ages. It does change biologically. We've talked about other health conditions. We've talked about the medications that our patients are on. We talk about organ function, things like how well the kidneys and the liver works. And we've talked about something called performance status. Performance status is a interesting concept that's been introduced many years ago now that looks at how functional a patient still is despite their cancer and their other health issues. And it ranges from 0 to 4. 4 means you're disabled, can't really carry on with anything. 0 is you're fully active. And this is kind of what's called a survival curve on the right there, and you can see that on this curve on the y-axis here, this is the proportion of patients that are still alive, and at the start, 100% are alive, and this is time on the x-axis. And you can see that those who have an excellent performance status, who are fully functional or just mildly restricted, tend to live in this particular study much longer than those who are not doing as well. And this is something that's replicated across multiple cancers, multiple treatments. So we know that this very crude measure called performance status actually predicts for response in many patients and can also predict for your ability to tolerate treatment. So this is one of the ways we have personalized treatment in the past. So what's new with personalized medicine? And this is a statement from the National Institute of Health in the United States, from the National Human Genome Research Institute, that personalized medicine is an emerging practice that uses an individual's genetic profile to guide decisions in regard to prevention, diagnosis, and treatment. And I think many of us actually think of this more as precision medicine, because as I pointed out, we've always hoped we've personalized medicine. And another definition of precision medicine is to deliver the right cancer treatment to the right patient at the right dose and at the right time, which you notice doesn't actually make mention of genetics, but that does come into play. So a little bit about the biology of cancer that helps us understand why this precision approach is important. Those of you who remember your biology class from high school or university, or never had a biology class, our cells contain a nucleus that has DNA in it, and the DNA is the genetic material. Then DNA is made up of these three nucleotides, G, T, C, and A, and the DNA is translated into something called RNA, and that is then turned into a protein. So each one of these, the little letters G, T, C, and A, can appear in a triplet. There are three of them together, and those three code for a specific protein. And protein is what most of our body is made up of. So the proteins are what create our muscle, our bones, etc. It's all very much protein based. If you have a mutation, then in that DNA, then the protein that's created can be wrong, or a protein cannot be created at all. And these are three of the common kinds of mutations. So here is one where this letter here should be G, but it's T, and instead of making an amino acid called tryptophan, you make an amino acid called cysteine. Here's one where the wrong letter is put in and it shifts everything over. And so now instead of having tryptophan, you have methionine, and the next one over is no longer valine, but it's glycine. So you've changed you've changed everything downstream of this mistake. Here is an A put in where there should be a G, and that is read by the protein creation system as a stop uh, notification, and so that protein creation stops there, and the protein is truncated. You can also have a bunch of things called chromosome rearrangements. So all the DNA gets wound up in these structures called chromosomes, and you can have, as in this example, translocation, where part of one chromosome moves on to the another wrong chromosome, and these guys kind of swap material, and that leads to significant mistakes as well. And there are other things called fusion proteins. So there's lots that can happen, and lots of mistakes that can occur. What causes the genetic damage that leads to these mistakes? So some of it is hereditary. You can inherit abnormal genes. This can be related to a variety of insults. So, for example, UV radiation. Every time you fly in a plane, you are bombarded by the same amount of radiation as getting with a chest X-ray if you fly from here to Vancouver. Chemicals can cause GNA changes, viruses, um, things like smoking and probably alcohol. And then just in the process of cell division, mistakes can happen and introduce genetic change. On a very simplistic level, many of the genes that are involved or implicated in cancer can be divided into categories called tumor suppressor and proto-oncogenes. And on the left panel are the normal genes. Tumor suppressors work as what are called brakes. And if they're normal, they brake the cancer development. Proto-oncogenes in normal tissue are off. So they're an accelerator, but they're turned off. If the genes get mutated, the tumor suppressor can be a defective brake and no longer stop the development of a process leading to cancer. Or the accelerator, the oncogene, can be jammed open, and so that it drives the development of cancer. I'm not going to go through this slide in detail, but these are some of the kinds of occurrences that happen in the DNA called single-strand breaks, double-strand breaks, DNA adducts, mutation. And below each one of these are the host of repair mechanisms that naturally exist in your DNA to try and correct abnormalities that happen on an ongoing basis. And our DNA is constantly mutating and constantly being repaired. And if you have mistakes in some of these genes, MSH2, MSH6, for example, BRCA1 and BRCA2, if you have mistakes in those, then that allows the mutation to proceed and to contribute to the development of a cancer. Cancer has a number of hallmarks, and as DNA mutates and you get accumulation of mutated genes, it can allow all of these processes to happen, evading growth suppression, avoiding the ability of the immune system to recognize the foreignness of the cells, um, allowing for the cancer cells to become immortal, which cells generally aren't, promoting tumor inflammation, allowing cancer cells to escape from where they originally live and metastasize or spread, allowing them to access the blood vessels, enhancing the instability and mutation rate of the genome, allowing the cancer cells to resist death, deregulating cellular metabolism, and sustaining the signal that tells the cancer to keep growing. Those are all the hallmarks of cancer. So, what guides the precision part of all of this? There are a number of ways we can look at which genes are mutated, and that can help us determine how that contributes to the cancer phenotype. And so here's an example of patient or of colon cancer. Um, and under normal circumstances, the cancer cells in a colon cancer will express these two genes, MSH2 and MSH6. So these are proteins that appear on the surface of the cancer, and we can use something called an antibody to show that those proteins are present on the cancer surface. And all this brown stuff is these two proteins on the cancer cells, telling us that they are present. Here is an actual colon cancer that is missing in the top one this MSH2 and the bottom one MSH6, and you can see that that brown is conspicuously absent from the cancer cells, which are the blue cells. And so the absence of these proteins tells us that one of the breaks that allowed the cancer, one of the breaks that would normally stop these cells from becoming cancer is absent. And that can have some very significant implications. And we'll talk about this a little bit later. A second way we can look at the mutations that are in the cell is to use something called fluorescence in situ hybridization. And so you take a cancer sample, you tease out the chromosomes, you amplify the DNA, you attach these fancy probes to it that will actually fluoresce under certain conditions. And the probes are things that are specific to the mutations that we want to see. And so in this particular instance, we're looking for a sequence of something called HER2, which is a gene that is often mutated in breast cancer and others. And we're looking to see whether there is more of this HER2 than there should be in the cancer cells. And so you get this kind of a picture. And on the far right panel, you can see, so the little green are what are called centromeres, and there should be one of those for each cell. And in theory, there should only be one HER2 in each cell, but you can see here in most of these cells, there's more than one little red dot. And that tells us there's amplification of this gene called HER2. And we know that that has ramifications for the patient. And then finally, on the technology side, this is the sort of up and coming and most important technology we have now, something called next generation sequencing. And again, we extract DNA, we break the DNA down into fragments. We can then use very fancy technology to amplify the fragments. All those go into a fancy computer and are analyzed, and that comes out telling us which genes are mutated. In the last couple of years, CancerCare Manitoba with Shared Health and Genome Canada and Genome Prairie has created a new genomics laboratory on the 6th floor in the McCharles building at CancerCare. And this has now got all these fancy looking machines which are running our next generation sequence platform. With this, we can look at targeted panel sequencing, which is what we do. We can look at between 20 and 350 genes per sample. This can be done relatively quickly in around 2 weeks and not all that expensive anymore at about $1,000 to look at. The cost depends on the number of genes you look at, but $1,000 for an average run. There are other ways of doing this, something called whole exome sequencing, whole genome sequencing. I'm not going to get into those. They're not done here. They cost more and they take more time. You can also have this done in a commercial lab where it can cost considerably more. And what the results that are spit out are they identify which genes are variants. So we're getting away from the term mutation because that has some pejorative implications and talking about variants that are predictive of developing cancer. And these variants can be classified with the ones we're most concerned about called tier 1 variants, those that predict a response or resistance to an approved therapy, or that are known in or have been recognized in guidelines as being prognostic or diagnostic for a diagnosis. And then tier 1B, those that predict response in well-powered studies but are not yet FDA or EMA approved. And then we get into tier 2 where they're probably significant, but we're not sure, and tier 3 where the significance is really uncertain. In Manitoba right now, we do something called a Q31 hotspot on our NGS platform. 31 refers to the number of genes that we interrogate each time we do a gene run like this. This is constantly evolving. We're constantly adding new genes to this panel or new aspects of the gene. And each time that happens, it has to be extensively validated to make sure that the results we're getting are accurate and meaningful. So it's a lot of work to maintain this. The current Q31 panel, so this is a patient result, looks at all of these genes and looks at all of these regions. So we have 31 genes and 97 regions on those genes where we're looking for what are called point mutations and insertions and deletions. So this particular patient with a melanoma, none of these genes was mutated. If there's a positive result, it spits out like this. And so this one says there's a mutation in a gene called MET. This is a patient with non-small cell lung cancer, and it tells us that this is a clinically relevant mutation. It's a pathogenic mutation. It's not one that we're not certain about. We know that this is one that drives cancer and potentially could be targeted with a treatment. Right now at CancerCare Manitoba, we do between 600 and 700 of these Q31 tests annually, most for lung cancer, colorectal, melanoma, something called a gastrointestinal stromal tumor, and brain tumors called glioblastoma multiforme. We also do testing for ovarian cancer for BRCA1 and 2, and we do some testing for blood disorders. So where does all of this fancy technology lead us? Kind of the meat here. So we can use some of this technology to identify populations at risk. So in Manitoba, we know that there are two so-called Mennonite founder mutations found largely in the Mennonite communities that are hereditary genes that are passed from one person to another that increase the risk of cancer. One is a mutation in a gene called APC, adenomatous polyposis coli gene. And if you have this mutation, you're likely to develop colon cancer in your 20s. Fortunately, it's rare. Much more common is a mutation in a gene called MLH1, which I actually mentioned a little bit earlier. And if you get this mutation, you're almost certain to get cancer and generally before age 50. Knowing these specific founder mutations greatly reduces the complexity and cost of testing because you know exactly what to go looking for in the genome of these particular patients if you want to make sure that they don't have this particular predisposition to colon cancer. We can also use this technology to screen for hereditary cancers. Um, Commonly now, we are screening in breast, ovarian, and prostate cancer for mutations in genes called BRCA1 and 2. And interestingly, screening for this not only tells us about the risk of cancer, but also tells us about the potential for treatment. And won't go into that today, but that's an important factor. I already showed you earlier on the immunohistochemistry panel lack of proteins for MLH1 and MLH2. And these are called mismatch repair gene proteins. And this has become a standard approach in Manitoba. Every colorectal cancer is tested for presence or absence of these proteins. And if they are missing, then those patients are then asked to submit blood so that we can try and analyze which gene is mutated and look at whether this is hereditary or sporadic, whether they just picked up this mutation. And what the implications are. There are implications for both treatment and for their family members. We can use the technology to predict prognosis. So in this case, a protein called HER2, which we've already talked about a little bit. If HER2 is overexpressed in breast cancer, patients do less well, but it also gives us an opportunity to treat them. And that's very important. So we'll come to that in a second. Also in breast cancer, many of the cells contain something called an estrogen receptor, and we can show that if that is present using that immunohistochemistry test, that those patients are going to have a better prognosis. And this is the 15-year cancer specific for survival for patients in an Ontario cohort. And the ones in red, who are all on average living longer than those who are green, are the ones who have this estrogen receptor. We can use this technology to rule out a treatment. So this is metastatic colon cancer. This is the liver here on a CT scan. There's a cancerous metastasis right there. It responded beautifully to chemotherapy and then it got chopped out. Right now, we know that every colorectal cancer metastasis is now tested for mutations in these three genes, KRAS, NRAS, BRAF. If you don't have that mutation, one of the treatment options for you are drugs called cetuximab or panitumumab. If you have a variation in these two genes, you can't get those treatments because they do not work. Similarly, if you have a mutation in BRAF, there are also limitations. You can use the technology to rule in a treatment. So these are PET scans on 2 lung cancer patients. You can see the primary tumor in both of them. In this one, the cancer has spread to the lymph glands and to the adrenal gland. In this one, it's spread to the liver. This is the brain. It's not a metastasis. And so we have this new fancy algorithm, which gets modified every 6 months at the moment, looking at how you treat patients based on the mutations in their cancer. And if they have a mutation in one of these 6 genes here, there's actually a specific therapy that we can use. And in each case, it's an oral therapy rather than IV chemotherapy, which is our first line treatment and can be extremely effective at slowing the cancer. Most end up going to chemotherapy, and many now go on to immunotherapy, but we now can target these specific genes with specific treatments. And this has greatly complicated the decision-making process in treating lung cancer that has significantly improved outcomes. I think in the interest of time, I was going to present very quickly. I mentioned this gene HER2, and if you have a mutation in that, there's a drug called trastuzumab. If you get that with chemotherapy, you live longer. A very new drug called erdafitinib. If you have a variant in this particular protein, FGFR, if you get this new drug as third-line treatment, about 40% of patients will actually have their cancer shrink. Immunotherapy is increasingly important, and we know that in patients with colorectal cancer who have a lack of DNA repair genes, those who get immunotherapy live longer than those who don't. And finally, a non-cancer specific gene called NTRK. And if you have a mutation in this gene, then an NTRK inhibitor can lead to a response. So this is how much the cancer is shrunk in all of these different cancers. We can also use this to try and help us sort out what a cancer is. So this is a huge mass in a young man's abdomen. It wasn't clear what this is. We thought it might be something called a germ cell tumor, which is similar to a testicular cancer. And we could do a specific FISH test to show that his cancer cells had an abnormal chromosome called isochromosome 12p. That's all these little red dots. And that confirmed to us that this was something called a germ cell tumor. Here's another patient with a very large mass in his chest. They thought it was a lymphoma and all the markers were negative. They thought it was a sarcoma and a specific test said it wasn't. And we were then able to determine that this was also a very unusual germ cell tumor. Finally, you can use this technology to try and avoid toxicity in patients. So there is a gene called DPD that helps break down a chemotherapy drug called 5-FU, which is very commonly used. If you're lacking this gene, you get severe side effects. And we can now and are starting to do genotyping to see who lacks this enzyme. It's only a small proportion of patients, but if you lack it, it's a profound effect. We're trying to see whether we can pick out who's lacking this enzyme so that we can choose a different drug or try and modulate how they get the drug in question. So the take-home message here is that cancer treatment has always been somewhat personalized. Modern technology is permitting a degree of precision in that personalization, It's worth remembering in medicine there are no absolutes, so it's not like this technology says you are going to benefit. And I think an important point is the rate at which the new knowledge is being acquired is staggering. The rate of change in the clinical realm is more modest, but it's clearly measurable. These are a couple of the important people that I spoke to prior to this talk. Paul Park, who leads the genomics lab in Shared Health, and Dr. Banerjee, who is our medical director of precision medicine and advanced therapeutics. And I will stop there and see if I have time for a couple of questions.
All right, thank you very much, Dr. Czaykowski. Yeah, lots of people thumbs up and congratulations on just one of the things that we've been learning throughout the morning is about that cancer, though we call it one disease, is so many more diseases. And I think your talk really illustrates how the idea of the personalized medicine is in precision medicine, as we get more and more precise, it's becoming more and more different diseases. So I'm going to try to do a couple of questions in the minute or two, and so the moderators overall the session bear with us. I'd like to take a couple of these really great questions. The first question was, does personalized medicine change the side effects I'll get?
A couple ways to answer that. So as the last slide there I showed, yes, in some instances it'll help us decide not to use a treatment because we know you're going to have problems. It does change the side effect you experience because it may change the treatment we would recommend for you, not so much because of the side effect profiles, but because, instead of giving you IV chemotherapy, we may give you an oral medication, which will have very different side effects.
Yeah, that's great. And as others are, some of the participants are observing in this, that there's a lot of things that are really exciting for patients based on your presentation. The last question I will ask is so who's eligible for genetic screening tests in Manitoba?
Yeah, good question. And maybe before I answer that, just to speak to your point, I think we always need to be very cautious because it is easy to get overexcited about this. There's a huge amount of development, but it isn't always pertinent to each individual patient. And even within those where we know that they have a mutation that might be targetable, they may not respond to treatment. So it's always important to take this with a grain of salt, if you like. Who's eligible for genetic screening? There are a huge number of criteria. Generally, it's when we see a cancer where we know that it has a potential for being hereditary, if there are clues that it is hereditary. So for colorectal cancer, for example, we're screening everybody now because passing on a mutated gene is actually fairly common. For other cancers, prostate cancer, it's about 5% are hereditary. Until recently, we didn't test. We tested very few, and now we are testing many more. But we do have some fairly strict criteria, and they are cancer by cancer, so it's not something that can be answered in a minute.
All right, thank you. I think it's really great to just even really emphasize how complex this is, and I think that gives the patients who are and their families who are listening to this an idea of when you sort of try to look out into the different things that are available for a particular cancer, but just how complex it is even for the experts, and how we're sort of trying to manage that the new science as it's coming on board. All right, so thank you very much again, Dr. Czaykowski, for a great presentation. I will sign off from this session, and I will see many of you in the next session.
Great. Thank you very much.